Well, thank you so much, everyone, for coming. Welcome to this conversation. My name is Sharon Bajaj. I'm a co-leader of the American Lung Cancer Screening Initiative, or ALSI for short. ALSI is an organization dedicated to raising awareness about lung cancer screening and really changing the game in that arena. To that effect, we've done some work working with city councils, such as the Providence City Council, to raise awareness through resolutions and proclamations. We've also worked with the House of Representatives and the Senate to introduce resolutions expressing support for Lung Cancer Awareness Month, which is actually in November. We've held other outreach events with other organizations, all to raise greater awareness about lung cancer and lung cancer screening. Now I would like to introduce Sabina Matos. She is the president of the Providence City Council. President Matos was first elected to the Providence City Council in 2010. She represents Ward 15, which includes the neighborhood of Olneyville, as well as Silver Lake and the Valley. In 2015, she became the first Latina elected as council president pro tempore in Providence's history, and in January 2019, she was elected as the first Latina city council president. So without further ado, Council President Sabina Matos.
Thank you so much, Simar, for the introduction, and thank you to all of you for taking the time and participating on this important panel. For us, it's so important to bring this message to our community and to the people of Providence and beyond. This is such an important topic, and as Billy expressed earlier, a member of our team unfortunately passed away recently due to cancer. All and his family has been in our thoughts and prayers. We'll be thinking a lot about him, and we just want to do figure what else can we do to help other individuals and prevent someone else from experiencing this terrible illness. So I'm going to do an introduction of our panel. And you guys have impressive resume, and I just was taking a look at it. If I read all of it, we're not going to have enough time to talk about lung cancer. So I'm going to give a brief highlight, so please pardon me. And so, Billy, we're going to make sure that your bios are attached to the stream so we can see it. So first of all, I would like to introduce Dr. Jeffrey Young. He's a neurology and surgeon at the Mass General Hospital and a member of the faculty of the Harvard Medical School. Dr. Young. Okay. The next we have Sharon Round. Sharon is a professor of medicine and pathology, laboratory medicine at the Warren Medical School at Brown University, and a staff of pulmonary critical care physician at the Providence VA Medical Center. Then we have Dr. Tom DiPetrillo. He's a clinical director of radiation and oncology at the Rhode and the Median Hospital. He's the leading authority on a variety of radiation treatment for cancer, including intensity modulated radiation therapy, and also high dose rate. Then we have Amy Nunn, is a professor of behavioral and social science at Brown University School of Public Health. She held a secondary appointment in the Division of Infectious Disease at the Warren Alpert Medical School at Brown University. And Simar, who we heard from at the beginning, Simar is the first GI Harvard College, and is concentrating in the history of science and a secondary in global health and health policy. So as you can see, we have a great panel here that are going to talk to us about what we can do to be able to address this illness for our loved ones and our community. So with that, I would like to ask the first question to get us going. And the first question is that nationally, only 5.7% of high-risk individuals screen for lung cancers, while the screening rate for breast cancer is over 10 times higher, around the 60s. what explains the social low rate for the screening of lung cancers, and what existing barriers prevent an individual from accessing lung cancer screening? I'd like to start with Dr. Yan. Dr. Yan, could you take down the question?
Great. Well, thank you so much, President Matos, and also Ms. De Los Santos for having us here. It's a real honor to be having this opportunity to talk to everyone. And I'm really honored to be talking along with Dr. DiPetrillo and Dr. Rounds and also Simar. So I think that's such an important question. So just to introduce to the audience who might not know, if for lung cancer, so lung cancer is the #1 cancer killer in America, and is also the #1 cancer killer in the world. And what it kills more people than people with breast cancer, colon cancer, or prostate cancer, which are the other really common cancers that we tend to hear about. And one of the best ways to find and one of the best ways to treat lung cancer is if you can find it early. And you can do that with what we call lung cancer screening, which is with a low dose CT scan. And unfortunately, right now, a lot of people who need to get screened for lung cancer aren't getting screened. And so I think that's the little bit of background to your question about why is only 5.7% of individuals who should be getting screened for lung cancer getting screened. And that is it's a complicated question, but I think you can think about it in terms of two broad categories. So in terms of patients, and then also with doctors. So I think that the data to show that lung cancer screening saves lives, that's relatively new. So that's been around since the big study that has really showed that lung cancer screening saves lives. It's called the National Lung Screening Trial. And that's only been around since 2011. And then in terms of finally getting health insurance to cover that, that really started after 2015. And so not a lot of people know about this. In addition, though, there are other issues that Simar has looked about, has studied deeply. And Simar, do you want to take a quick stab at like what other barriers?
Certainly. So I think that on the patient side, one of the large issue is stigma. And I think that ultimately there's a large stigma associated with lung cancer. We often view lung cancer unidimensionally as being caused by smoking. And as a result, the disease is one where we blame the patient oftentimes. Oh, that this person got lung cancer because they smoked, which is not a fair thing to say. And often it leads to that stigma being internalized, and that person might not be willing to seek out lung cancer screening. If their primary care provider asks, how many pack years have you smoked, in order to determine whether that patient is going to be eligible for lung cancer screening or not, they might not be as forthcoming because of that internalized stigma. So stigma itself is a large barrier to lung cancer screening. And I think what Dr. Yang brought up about the newness of the recommendations, the newness of the low-dose CT in the public consciousness is another point, because it expresses itself both in terms of patients who have not heard about it, and that providers who may not providers who may not understand completely the recommendations because they're so new, and as a result, not implement them in the way that they might need to be.
Could I agree with everything that people have said. I do want to point out, though, that the American Lung Association released its state-by-state lung cancer scorecard just last week. This is a very important document. And in Rhode Island, we're a little bit better. We're better than the national average at 10.5% of high-risk individuals being screened. So we can at least be grateful for slightly better statistics.
So I just want to continue with the stigma. Why do you think the stigma is so high, and what can we do to address that? And I don't know, is there maybe Dr. Nunn, do you want to share some thought of this?
Yeah, absolutely. Thank you for the opportunity to be here this evening. I'm sorry I was a couple of minutes late. I'm also glad to see one of my mentors here, Dr. Rounds. I am not a lung cancer expert, but I do know quite a bit about stigma because we do a lot of work in sexual health and HIV. And one of the things that's quite similar, I would say, across, and HIV is now considered a chronic manageable illness, but it's another disease that's still heavily stigmatized because of the way that people contract it. And I think what has been, and we run a lot of different projects at Open Door Health, which we run, owned by the Public Health Institute. It's an LGBTQ clinic, but also in other parts of the country. What works in fighting stigma, I would say, is media campaigns that affirm the value and dignity of people so that people feel comfortable talking about cancer or something that's heavily stigmatized. And also just normalizing conversations around it. You know, that if we can push screenings out and have primary care physicians help us identify who should be screened, for example. Just having conversations with patients so these things are normalized helps fight stigma.
I mean, it really
You
drives home.
Remember too.
Can you hear me?
It
really drives home the
ahead.
point when you look at the screening numbers. It's much more likely that a person who has stopped smoking is likely to start screening rather than someone who's continuing to smoke actively, which I find really intriguing. I mean, more than, I want to say 2/3 of the patients that are screened are those that have stopped smoking. And again, I would like to put a little plug in here for Dr. Rounds and her team at the VA. They had actually one of the earliest smoking cessation programs and were very successful with that. And I think it's important to say now and throughout this talk that the #1 reason for lung cancer is smoking. We have to find a way to stop people from smoking. That's #1.
Mm-hmm.
Then above and beyond that, lung cancer screening does help. Catches earlier cancers. If you look at Rhode Island's numbers, Sharon, you mentioned this, is that when we got our scorecard, we found that Rhode Island actually had, I want to say, a 10 or 15% increase in early cancers that were identified. And for those cancers, there was about a 50% improvement in overall survival.
Yeah, I agree. I think the fact that Rhode Island is really one of the nation's leaders in lung cancer screening rates, that's definitely something to commend. And one of our team members at ALSI, Adita Kaplan, actually called, just trying to learn more about the lung cancer screening in Providence and Rhode Island. But she called the screening centers in Rhode Island. So Landmark Medical Center, Rhode Island Medical Imaging, Roger Williams, and 7 other ones. And it's really, it was easy for us to actually talk to the screening centers. You know, you didn't have to wait like an hour the way sometimes when you call the airline and things like that. You just, somebody picked up the phone and really got you, answered your questions about what kind of insurance they took, which they take Medicaid and all kinds of insurance. So it's really, what Providence and Rhode Island is doing is great. So.
But we've got improvement.
Absolutely, yeah.
And a lot of the work in Rhode Island has been spearheaded by Dr. Terry Healy, one of the radiologists that was on the National Lung Cancer Screening Study and has maintained that throughout the state. Just one more thing about the state. It was the first state in the country to show that breast cancer screening led to an improvement in survival. So it's a small population that doesn't move much. So certainly screening studies should be very effective in Rhode Island. And we've tried to combine with the state to try to make our program stronger.
Yeah, actually at the VA, we had a lung cancer screening program in place for 4 years. And before that, we had a very rigorous follow-up program for lung nodules so they wouldn't slip through the cracks. And we've published this data in the first 3 years of our formal lung cancer screening program, which was done in conjunction with primary care physicians, radiologists, surgeons, and medical oncologists, and radiation oncologists. We found that the number of early stage 1 diagnoses increased to 48%, and before that it was down around 20%. We can't say we've improved mortality, but there's no question in my mind that we are diagnosing at a more likely to be curable stage. So it's good, but we've got room for improvement everywhere.
Dr. Ram, tell us more about how can we facilitate the conversation between the patients and primary care providers about the screening?
Yeah, this is a really hot area now for research in health services and outcomes research, at least in the VA and with the NIH. There's no question but what there needs to be a conversation between the provider, whether it's a physician or an advanced practice provider, and the patient. The patient does need to understand the pros and cons of screening. And there are cons for some patients. It's not a good idea for some people. And so how do we go about facilitating those conversations? And one is that patients need to be educated. What they would benefit from education to ask their providers, and the providers would be benefited by education and even by incentives, institutional or practice incentives to ask the question. So for example, in the VA, the primary care providers get a clinical reminder once a year for eligible patients saying, have you done your lung cancer screening conversation? If the patient is not appropriate for lung cancer screening, they can respond to that through the electronic health record. And if they are, this is a way to remind them to have the conversation with the patient. And if they are eligible and appropriate for screening, then to start the ball rolling. But I think their education of patients and providers, as well as prompts in the electronic health record, can facilitate this. And then how to do that conversation in a non-threatening, non-stigmatizing way. There we need the social scientists like Dr. Nunn to help us do this in a way that's both appropriate as well as effective.
Thank you. I know there's some Facebook questions coming in. I just want to ask Simar, can you help me with the Facebook questions? Do you have them visible to you?
Of course, yeah. I can ask the Facebook question.
Thank you.
So there was a question from Facebook that asked, do you think that the reason behind 2/3 of the patient population that is getting screened are former smokers is because of the stigma that prevents current smokers from pursuing lung cancer screening, or because primary care providers are less likely to discuss lung cancer screening with current smokers? Is it one or the other, or perhaps a combination of both?
If I can take it, that's a great question. I think when you think about primary care physicians, they have to meet 3 criteria to have lung cancer screening reimbursed. Number 1 is that the patient has to have the appropriate number of smoking pack years. They have to be between ages 50s, 55 and 65, whatever. And then they have to be able to offer a smoking cessation program with it. And that's where many communities fall short. And that's part of the education that we have to bring to all our physicians, particularly those that are trying to coerce their patients into lung cancer screening.
Thank you. And I just want to go back to actually for Dr. DiPetrillo. Just getting a mammogram for breast cancer is relatively a streamlined process, and it's also like almost happens regularly. But getting a low CT scan, however, requires a shared decision-making process, which can itself be a barrier against lung cancer screening. What role, if any, should a shared decision-making play on the future of lung cancer screening?
I think that was for me. They actually can be streamlined, much like breast cancer screening and mammography was. The exam actually takes the same amount of time, if not less time. There's no pain in getting a lung cancer screening CT, actually straightforward. It's just getting the patients arranged for that. It's a little more difficult to get time on a CT scanner, though the scans are really quick. But, you know, I think that once you've got an engaged patient, you certainly can get them to get their lung cancer screening rather easily. Then what happens after that is a series of events. So they really have to be educated before they start, because many smokers will have abnormalities in their lungs that are not cancer. And they have to be prepared that there may be some abnormal findings that are not cancer.
Does anybody else want to add to this?
Say that again?
I just wanted to see if any anyone else wanted to add also to this topic before I move on to the other question. I'm gonna check.
I just want to add
yeah, go ahead.
That's both just from my professional work experience, but also my lived experience. So I'm a breast cancer survivor myself, and thank goodness. And I was diagnosed because I was screened early. I think one thing that the breast cancer, people with lived experiences with breast cancer have done so effectively is mobilize millions of people around their cause, because and it's a brand, and it's a community, and it's philanthropy, and they get people who have survived involved, as well as all of their families and loved ones and their trainees. I mean, it's a deep network. And I think when you think about, and it has had a hugely positive impact on many public health activities, and also on getting mammograms back into guidelines, however controversial that has been, you know. So I think that having a community of influencers behind a public health push, just the impact can't be overstated. You see that also with the gay men's social movement in the 80s and 90s in the US around HIV, and the breast cancer movement is just so powerful. And so I think just getting patients involved to be spokespersons rather than people like us, you know, boring professors and doctors, you know, people who are influencers, I think has a huge impact on, you know, positive push forward.
Yeah, I want to point out that, you know, one of the very sad events of the last decade has been when Dana Reeve was diagnosed with lung cancer and actually passed away from it. Dana Reeve was the wife of Christopher Reeve, who was Superman. And she had been very active in promoting the health of quadriplegics after her husband's tragic accident. Reeve was a non-smoker, and she died of lung cancer. So there was quite a bit of publicity and interest in screening after that sad event. But I think, you know, we need more champions like her, but not with that example, unfortunately. Mm-hmm. But one thing to remember is that lung cancer, after you screen a patient for lung cancer, if you find an abnormality, there's a need then to decide what to do about the abnormality. And in very elderly people or people who have serious heart or lung disease, who are perhaps not really going to be able to survive even diagnostic testing, lung cancer screening is probably not such a great idea because it only causes them great anxiety and may or may not be appropriate anxiety. The other thing to keep in mind is that only about 2% of nodules found on lung cancer screening CTs actually prove to be malignant. And the diagnostic workup, which is my trade, is diagnosing the nodules, there are side effects. And not everyone should go through that diagnostic testing process. So a shared decision-making between the physician and the patient is absolutely crucial before embarking on lung cancer screening, so that the patient really does understand the consequences of a positive scan and the potential risks and benefits of actually going through the diagnostic workup. It's a little different from breast cancer in that the side effects and the morbidity of the diagnostic procedures for breast nodules are not quite as significant potentially as those for lung nodules.
But the treatments for early stage lung cancer are very, very successful.
Right. And they're getting.
Go ahead.
And they're
I was going to say that I agree with what Dr. Rounds and Dr. DiPetrillo were just saying, that there are side effects to biopsies and interventions. The good news is that, fortunately, from the studies, for example, the National Lung Screening Trial, and also the newest study that just came out from Europe called the Nelson Trial, the side effects, the rate of bad things happening is actually low. And then if you catch it early, whether it's through surgery or if somebody's really on the older side and maybe not be able to do well with surgery, if they get what's called a particular type of radiation called SBRT, or stereotactic body radiotherapy, that works well too. So there are options for treating that, not just surgically, for folks with a lot of medical problems.
Thank you. I want to go back also to Dr. Round, because if so many women died of lung cancer, but just as Dr. Round was saying, we hear a campaign about breast cancer all the time. What other things we can do to create more awareness? And also, what are other causes of lung cancer? Because when we think about smoking, what are other risk factors?
Well, secondhand smoke is certainly an important risk factor, particularly for women. In other parts of the world, exposure to biomass cooking materials in the home is a risk. Radon, which gets a lot of press here in New England, is a risk. Asbestos, working with asbestos, is a risk. And certain chemicals can be a risk. And sometimes we just don't know why one person who is a non-smoker develops a lung cancer while another person does not. It certainly also probably relates to their genetics and increased susceptibility. But sometimes we just can't identify a specific cause.
Thank you. I'm going to go back to Simar. Simar, did you have another question you want to ask Sana?
Yeah, I mean, I think that really honing on that question about women and lung cancer among women. In fact, someone mentioned the Facebook question is that by 2035, it is estimated that more women will die from lung cancer than men. And Dr. Rounds mentioned that secondhand smoking is one of the issues that causes lung cancer among women. But what are the other, how can we target that? How can we raise more awareness about lung cancer among women and raise awareness to this very significant issue that is often not highlighted as significant?
Well, first of all, Virginia Slims had a very effective advertising campaign in the 1980s and 90s. You've come a long way, baby. So now you can start smoking. And now we're starting to see women in their 60s and 70s who, you know, took it up. And that is really, really unfortunate. Education is critical. I personally feel that vaping, electronic nicotine devices are not, particularly those that use the flavors like bubble gum or mango or whatever to entice adolescents to become addicted to nicotine. I fear that we may be facing another surge of cigarette smoking adults in another 20 years with lung cancers. So prevention and education and removal of the stigma.
Thank you. That I had for all of you, the panelists, what is the breakdown of the lung cancer when you looking at the different demographics? We see any demographic that seems to be having like higher issues in lung cancer that we should be paying more attention to?
Amy, do you want to take that?
Oh, you go ahead, Sharon.
Well, I'll just point out from the American Lung Association statistics, cancer statistics from last week, that their minority populations, such as African Americans and Hispanics and Native Americans, do tend to have a higher mortality from lung cancer more nationally. And this may relate to reduced access to screening and to care. In Rhode Island, we're doing pretty well as far as that's concerned, but nationally, it's a problem with access for minority populations.
And then I can add to that, certainly that among African American men in particular, there's exhibit the highest rate of cancer deaths. And so this is a significant issue, like among African American men nationally, 42.3 per 100,000 die from lung cancer. And that's compared to 41 for Caucasian males and 22.2 for Asians. So it's a significant issue that we need to tackle, especially among minorities. And I think raising awareness about disparities in lung cancer and lung cancer screening is another target of educational efforts.
You're muted.
Thank you. Thank you so much. So a few months ago, the chair of the Congressional Lung Cancer Caucus, Representative Brenda Boyle, introduced a bill as the Catherine Lung Cancer Early Detection and Survival Act 2020 that would require the private insurance plans to cover without cost sharing of screening for the detection of lung cancers for individuals 40 years of age and older, without regard to such individuals' smoking history. So I want to ask Dr. Yan, what are your thoughts on this bill and the larger idea of loosening the cancer screening requirements?
Great, thank you. So I don't know if Dr. Rounds, Dr. DiPetrillo, or Dr. Nunn, if you have heard about this act or this bill. It's called the Catherine's Lung Cancer Early Detection and Survival Act of 2020. And the goal of that is to require private health insurance plans to cover, without cost sharing, screenings for the detection of lung cancer for individuals 40 years of age and older, without regard to such individuals' smoking history. So my own take on this is that it's a good intention, but it's probably not where we want to be going right now. So because we don't have data on folks who are younger and who have never smoked. And that it's a very important topic though, in terms of what should we do for, so right now, just to remind the audience or just to share with the audience in case you don't know, there are strict guidelines for who should be screened for lung cancer. And for the people who should be screened, it's really focusing on folks who have either smoked or are currently smoking. And even in that group, there's still debate among the medical community as to, because one of the guidelines is you should, if somebody quit smoking 16 years ago or 30 years ago, they're not currently eligible for lung cancer screening right now. And then right now among the medical community, there is debate on whether or not you need to have that quit date cutoff. But so I think that President Matos, just to answer your question, and then I'm curious what Dr. Rounds and Dr. DiPetrillo think, and Dr. Nunn. I think that probably we should just focus on really sticking with the guidelines and with the data right now, but that it's going to be really important to continue to study the risks of getting lung cancer for non-smokers.
I totally agree. I think this is premature. It's not based on data. It's going to result in a lot of benign nodules being revealed, and in other parts of the country, such as in the Midwest, the Ohio River Valley and the Central Valley of California, the Southwest, there are very common fungal infections that produce lung nodules. And to be picking those nodules up, telling a patient they have a mass in their chest, and we don't know what it is, and maybe it's nothing, maybe it's cancer, the patient suffers anxiety from this knowledge, and it results in a lot of unnecessary diagnostic procedures, in my opinion, for if this is broadened in this way. So until we have better data, I think it's premature, to be perfectly honest. I agree completely.
Thank you. I'm going to go back to Simar for another question. Simar?
Yeah, I wanted to first, before going to that question, I wanted to share some data regarding the disparities that we hinted at a little bit earlier. So let me share it. So you can see that first off, I wanted to show that in Providence County, the number of cases of lung cancer, bronchial cancer. So between 2013 and 2017, that was at 2,640. And in fact, I wanted to then focus on the disparities and show you what the national data is. You can see this is rate of new cases, and that you can see that among white Americans and Black Americans, it is relatively similar. And you can see that in the lighter blue, that is the Rhode Island data. But I also wanted to show you that more generally, what I was mentioning before about among African Americans, that they exhibit the highest rate of cancer deaths of all ethnicities. So I think this is just really I wanted to show you this data in order to bring that topic into, spotlight that topic of disparities.
But also in talking about that, in a screened population like Rhode Island, where there's double the national screening, there has been an increase in early cancer detected. And when you look at racial disparities, in fact, there's a doubling of how many Black Americans undergo surgery for early stage lung cancer. There's about a 40% improvement in how many Latinos undergo surgery for early stage lung cancer. So in the right population with the proper screening program, the appropriate treatment can be manifested pretty easily.
Thank you. Dr. Round, were you trying to say something? Okay, thank you. So just taking time, I want to make sure that all of you have an opportunity to send a final message before we end this panel. And I just want to give you the opportunity to help us bring home the message of the importance of the screening and the importance of paying attention to the issue of lung cancer. So I'm going to start with, let me start with Dr. DiPetrillo. You're muted, Doctor. Sorry.
Done. Could you repeat the question, please? I have a fan blowing in my background.
Sorry, I was checking out the time, so we're coming close to the end, and I just wanted to have the opportunity to all of you, if you have a final message to the public that has been tuned in about this, the importance of this topic.
Well, my message is the same message I started off preaching about, is if there's a way to stop smoking, stop smoking. That's 90% of lung cancer diagnoses are associated with smoking. Lung cancer screening picks up early cancers. There's very successful treatments for early lung cancer. The difficulties in stopping smoking, there are programs by which one can help a person get through those difficulties of trying to stop smoking. It helps. And we know that when people stop smoking for an extended period of time, their risk diminishes almost to a normal population. And the last thing is to not have our young children or adolescents start smoking, start vaping. We've got to prevent that from happening.
Thank you so much. So next I'm going to go to Dr. Nunn.
Thank you so much. So we operate Open Door Health, which is an LGBTQ clinic on the west side of Providence, Rhode Island's first and only clinic dedicated exclusively to that mission. And LGBTQ populations have much higher rates of cancer and also much higher rates of smoking. And what the message that I want to send is one of action and just affirmation. So our clinic is here to serve you, including all of your health needs, whether it's lung cancer, smoking cessation, or anything else. Our door is open.
Thank you. Next, I'm going to go to Dr. Ram. And Dr. Ram, can you also just remind everyone that even though we have the pandemic with COVID-19, we still have all the health issues that we want to address? Thank you.
Yeah. Well, my last word is that I would encourage all patients who are at risk for lung cancer because of a history or of active smoking to enter into a conversation with their primary care provider about whether they should have lung cancer screening. With regard to screening during the COVID-19 pandemic, this has been a tough problem. In our practice, we noticed that fewer patients were keeping their appointments for screening CTs because of fear of going to the hospital, and not unjustified fear, I might add. We have prioritized surveillance of nodules over surveillance as in the second wave of the pandemic that's reaching Rhode Island now. However, I fear that we may see more stage 3, stage 4 cancers in a year from now because of missed screens. So this is could could become quite a public health problem. And I personally would like to see screening proceed as usual, but I have to be sympathetic to the fears of patients about contracting the illness when they get into the medical care system. They're serious concerns.
Thank you, Dr. Ram. Next, I gotta go with Dr. Yan. Dr. Yan, can you please share with us some parting words with this regarding this topic?
Thank you. I agree with what everyone has said so far, that please, if just in the audience, and also if you have a family member or a friend who might be at risk for having lung cancer because of their history of smoking, to tell them about what Dr. DiPetrillo has been emphasizing with smoking cessation, and then also what Dr. Rounds has been saying about getting screened for lung cancer. So I'm in Massachusetts, in Boston, at Mass General, and we have been fortunate that even during COVID, even during the pandemic, we still have kept up with our lung cancer screening, because a lot of the imaging centers are outside, they're not in the hospital. So I would say just to please still talk to your primary care doctor, and because to get screened might not be as hard as you think it might be, even during the pandemic, because a lot of these imaging centers, and I think in Rhode Island it's the same way, they're very well run. They have safety measures, everybody takes safety very seriously, and so to continue keeping that in mind. And then if anybody has any questions about lung cancer screening, I would also just put in a shout out for our nonprofit, which is the American Lung Cancer Screening Initiative. There's a lot of good information on that website, which is probably available, right, on Facebook, or yeah, so to look at that.
Yes, Billy and Ziggy are adding that information to the Facebook Live chat also. I would like to give the next opportunity for Simar. Simar is the fourth make this happen. So I just want to give him the opportunity to give us a final message, and thank you for making this happen.
Certainly, I think that a quote by Dr. Douglas Wood, he's the chair of the Department of Surgery at the University of Washington, is something that I would like to end with, really. He said that lung cancer mortality reduction attributable to annual screening with low-dose CT imaging is the most profound advance in the war against cancer in a generation. I think the importance of low-dose CT cannot be understated. Certainly, we have to start with smoking cessation, as Dr. DiPetrillo has mentioned, but low-dose CT holds a special importance, and Providence and the greater state of Rhode Island is doing a terrific job in that arena with a screening rate of above 10%, but still there's a lot of room to go. There's a lot of work that can still be done, and we should applaud the efforts that have taken us to this 10% mark, and then still aim for more. The implications for mortality, more generally, they're vast, and they deserve that proper attention. And I think that ultimately, that's where ALSI as an organization, that's where we're trying to make an impact. And I think if we can work together through educational efforts, we can really make a difference in this arena and save lives.
Thank you. Once again, I would like to thank Dr. DiPetrillo, Dr. Round, Dr. Yan, Dr. Nunn, and Simar for joining us for this important discussion. The doors of the Providence City Council are open for all of you. Whenever you have any other message that you want to bring to our community. Thank you for participating, bringing this information forward. And we're going to be here to help you whenever you have an important message that you want to to the community. It's been a pleasure, and looking forward to the next time.
Thank you, Sabina.
Happy holidays.
Happy Thanksgiving,
Thank you so
everybody.
much.
Thank you.
Happy Thanksgiving.
Thanksgiving. Thank you.